Leonardo da Vinci has described the human foot as a masterpiece of engineering and a work of art. We have got 26 bones in the foot, 107 ligaments, 19 muscles, 125 sweat glands. If we say that a person walks around 7,500 to 9,500 steps per day, it is roughly around 185,000 kilometers in his lifetime, and it's going around the world 4 times. So this is the most abused organ of the body, and we don't care for it. These are the as anatomy goes on. The majorly we start with the arches. Arches are formed with bones, ligaments, and tendons. Their main function is for weight bearing, locomotive organs, for walking and running, provide spaces in the sole to accommodate muscles, nerves, vessels, and provides stability and support. Medial longitudinal arch, it runs from the most prominent arch of the body. It runs along the inner margin of the foot. This arch absorbs majority of the shock and impact while walking, jumping, and running. Medial longitudinal arch is formed of apex by the talus and two extremities, that is medial tuberosity of calcaneum and the head of first, second, third metatarsal head. It is formed from callus, talus, navicular, three cuneiform bones, and first three metatarsal bones. Longitudinal lateral arch, which is found on the most lateral part of the body. It is basically formed from lateral tubercle of the calcaneum, head of fifth and fourth metatarsal head. It is flat arch, mainly occupies formation because of the bones. Transverse arch, which runs along the midfoot, lies at the level of transmetatarsal joint, provides support, flexibility of the joint. The arch is maintained by muscles, ligaments as the longitudinal arches form. The major factor of maintaining the arches are your bones, which are interlocking with each other, muscles, and ligaments. Maintenance of longitudinal arch, which is mainly the shape of bones which interlocks with each other, the tendons which run across the arches, and the ligaments. We have got a very strong ligament in the plantar surface. It is basically not a plantar surface, which is called as a sling ligament, which is exactly a plantar aponeurosis, arises posteriorly from the calcaneum and distally divided into 5 more major branches, which continues as fibrous digital sheets and enclosed with the flexor tendons of the toes. It has got flipping action, where you can see the once it is tightened up, the first metatarsal goes up. So this is called as a whiplash mechanism. This is what the mechanism looks like, and this mechanism is hampered in diabetes, and because of which the first metatarsal head get more pressure while walking. That is the reason why we get a first metatarsal head ulcers frequently in a diabetic foot. Ligaments, we have got major 5 ligaments: deltoid, lateral ligament, spring ligament, strong plantar ligament, and long and short. The spaces which Madam has started upon, I will approach more enlightenment on that. Medial plantar space, that is the dorsal is from the surface of first metatarsal head, medial from plantar fascia extensions, laterally from intermuscular spaces. It contains of abductor hallucis longus, flexor hallucis longus, tibialis posterior, and list other things. Central plantar space is formed laterally by plantar fascias, inferiorly by plantar fascia, laterally by intermuscular septum, and dorsally with transmetatarsal joint. It contains flexors, longus, brevis, lumbricals, and the rest of the muscles. Lateral space, which is formed dorsally by fifth metatarsal head, medially by intermuscular septum, laterally by plantar fascia. So this is what the concept. If you can see the arrows, A is your medial, B is your central space, and C is your lateral space. The infection coming into that space will extend and infect the tendons and the muscles in that space and lead to spreading of it. This is the cross-section study: medial, central, and lateral. If we say that the central plantar space has an abscess, then the septic arthritis occludes the plantar arch, which leads to necrosis of the third, fourth, or second toes. This is the image, and this is what the debridement comes to. Because we need to debride the whole space, we need to remove complete infection. So this is what the debridement goes in. The lumbricals are considered to be the major plantar flexures of the metatarsopharyngeal joints and extensor of the interpharyngeal joints. So this is the anatomy of the deep plantar fascia. You can see it right extends from, the pointer is not pointing it up, right from your calcanea towards your soles. So this is the deep plantar fascia. It holds, protect the feet. It has got a major support for the longitudinal arches. We have got 20 muscles individually in the feet, 14 on the plantar aspect and 2 on the dorsal aspect. So the muscles which are on the plantar aspect, which are divided into 4 layers, and the muscular actions are not that complex just because like our hands. They only act together to support the arches and in the locomotion point. This is the main joint, which is called a subtalar joint or talocalcaneal joint. Inversion and eversion is the movement which occurs at that joint. If the joints collapse, the foot is not going to work. So we need to protect this joint. Nerves and arteries, tibial nerves and posterior tibial artery divides in posteriorly towards the medial malleolus into medial and lateral plantar and supplies the intraosseous muscles. This is the venous arch, where superficial venous arch and the superficial cephalic vein and the great cephalic veins meet each other, and the main what we say it as their clinical implication is varicose veins and venous thrombosis. Dorsalis pedis artery we can see running straight along the tendon, and this is where the arch is formed dorsally and supplies to the deeper plantar arteries. This is anatomically where we can judge the dorsalis pedis, we palpate it. This is what the anatomical structure goes in. This is another space called as tarsal tunnel, which is formed between the bones and the flexor retinaculum. This is another one point where the tibial nerve is being compressed. If there is an infection, inflammation, or tumor or fracture over there, this can lead to numbness and burning sensations and tingling sensations. So this thing has to be analyzed or diagnosed before labeling the person to be diabetic neuropathy straight away. These are the fascias where we can see that there is connections. Okay, you can see this. So this is where the infection spreads along the fascias. The most important understanding point is that these are various compartments. Just like the legs, we have got various compartments in the foot also. If the infection happens in the compartment, then we need to remove the tensions from the compartment, or else everything would be necrosed. This is from surgeon points of view, and as well as physicians should know that, so that the extent why this debridement is needed, the physician has to know it, so that we can guide the patients and help the patients. So this is on the plantar view, where you can see lateral, central compartment and the medial compartments, and these are the fascias which has been entangled. Floor is more complex or compromised, or compartments are more rigid. So the plantar aponeurosis is the outermost fascia and represents the anatomical layer located beneath the subcutaneous tissue. The medial and the central plantar compartments are separated by the medial sphincter space, which we have already discussed. So infection in these spaces need to be tackled very carefully. We need to reach to the fascia. Just merely removing the unwanted tissue is not going to help. The same thing has been there. This is the cross-sectional sections, medial, central, and lateral spaces have been described. I'm just running out because previous this thing, the transverse foot space, where we need to remove this complete toes, so that the debridement is to be removed, so that so that the spaces and the infection won't spread further. So the infection usually spread along the tendons. Any kind of tendon infected area is going to spread along with it. So this is what the central compartment's instrumentation is done. So if you can see, it is more deepened in. So central compartment needs to be removed completely or explored completely to prevent further complications. This is necrotizing tissue. Need to remove the tissue completely. This is where the flexor hallucis longus tendon has been. Yes. Nah, this will do. This is flexor hallucis tendon. We can see. So that tendon is between the two sigmoid bones. So osteomyelitis of sigmoid bones or any inflammation of sigmoid bones, this tendon is going to get infected. So the ulcer or infection of the first metatarsal head is going to go along the flexor hallucis longus tendon. So you need to track the tendon and remove it so that the infection is to be prevented. This is another example where the extensor tendons has to be removed completely. The space has to be removed completely so that we can prevent further complications. This is another way where a lower pressure area is being infected from the higher pressure area. So this is a high pressure area. While we walk, this is a high pressure area. And once this is osteomyelitis of the third metatarsal head, and this is what the dorsally we can look like. So from lower pressure area to the higher pressure area, the infection spread. The infection rather can spread through the interosseous spaces or interosseous compartments. Third metatarsal, third toe spreads along that. So we need to remove completely because the interosseous has been infected. So need to remove it so that the further prevention of or spread of the infection is being done. The simple fact, I will just take 2 minutes. The simple fact is that the bipedal gait requires that the high weight bearing is to be from the bottom of the foot. So this has been, everybody knows that neuropathy, vasculopathy and immunopathy and injuries are the most common problems which the diabetic patient faces. Pathobiomechanical changes due to the peripheral neuropathy is the main etiology. This is what it is: sensory neuropathy, loss of sensations, inability to feel high pressures, loss of position sensations, changing walking pattern, hyperpronation, and the muscle weakness, imbalance, stamping gait. We need to have a high index of suspicion. Diabetic foot patients are very vulnerable. Neuropathy, immunopathy, and altered biomechanics. Very narrow window of opportunity is there. No complication, no examination is a philosophy. That is not going to be there. If a neuropathic fit comes in, high stamping gait, if slips out, sensory neuropathy, drop of the foot, ulcer with walking comfortably, it's severe neuropathy. So once you can see the patient walking in, we can guess clinically what exactly it is. 85% of diabetic foot ulcers are from within out. So repetitive modern force or prevention of walking by will damage more. Diabetic foot ulcer is a mechanical problem. No amount of antibiotic or dressing will heal the wound unless and until you reduce the pressure. This is the main crux. So this is the current scenario and what we call it as a foot attack, just like an heart attacks. So main aim of diabetic foot care is to prevent the ulcers, prevention of ulcer, prevention of ulcer, and prevention of ulcer. Nothing else. This is a diabetic foot. It's calling to us, please help me, please save me, please save me, please save me. Thank you for your patient listening.